Professor Dr. Vivek Gupta, Senior Interventional Cardiologist in Delhi Apollo Hospital, working there, and before that I was working with Professor Alain Cribier in Charles Nicolle Hospital in France. This is 15th of April, and we had a talk in the API, Association of Physicians of India conference in Jaipur. It was a very nice conference they organized. So my topic was post-bypass angioplasty, and this is a topic very important because we see many patients who have undergone bypass surgery many years back, and they come back with unstable angina or stable angina or acute coronary syndrome, and these patients are actually now requiring more and more intervention procedure. As of now, we know that saphenous vein graft, which is one of the important armamentarium in the surgery, when bypass surgery is done, there is a Lima graft, which is left internal memory artery, which is mostly given to or attached to the left anterior descending artery, and because of to cover the other blockages, either you should do total arterial grafting, which is right internal memory artery, but most of the surgeons in India and outside India, they are doing only one Lima and one or two or three saphenous vein graft depending upon the blockages. Saphenous vein are taken out from the legs of the same patient, and then with the reverse grafting done from the aorta to the location just distal to the stenosis, either in obtuse marginal or posterior descending artery or in the diagonal branch. These are the grafts which are more vulnerable to blockages, reblockages, reocclusion. Why this happens? Because saphenous vein graft have a shelf life, because it's finally inside the body, life which is, the data has shown that at 10 years of follow-up, more than 50% of saphenous vein graft, more than 50% of the saphenous vein graft get occluded, and if you see 5 years, more than around 30% of the saphenous vein graft will get thrombosed or degenerated, and that's why the hampering the flow to the artery, and that leads to unstable or a chronic stable angina or any kind of acute coronary syndrome, and sometimes acute myocardial infarction. So these patients, when they come to the interventional cardiologist, we do check angiography, and then we find out the blockages, where the blockages are there, and depending upon the blockages, we would like to do angioplasty of that lesion. Now, when we do angiography of post-bypass patient, we check the left anterior memory artery. We of course see the native arteries, left main artery and the right coronary artery, and after that we will do a left internal memory artery by hooking through the subclavian artery, and then we will see the graft, and out of 2 or 3 grafts, most of them they get either occluded at the 10-year follow-up, or they are not visualized. Mostly they are blocked at the ostium itself. So it becomes a challenge for the interventional cardiologist to find out which artery to be revascularized. If we find that one of the saphenous vein graft is occluded at the ostium and there is no flow coming through that, then we would like to approach the native artery, and native artery angioplasty, if it is chronic total occlusion, for example right coronary artery, or it could be 99% occluded or 80% stenosis, then it's very simple to put a stent in the native artery rather than approaching the saphenous vein graft. But many times it happens that because of during the acute coronary syndrome, the patient graft get diseased because of degeneration, and then of course the angioplasty of the saphenous vein graft becomes preferable as compared to the native artery, because native artery may not be amenable to angioplasty. So these are the graft, and the angioplasty of graft was the main topic of today's lecture. So graft angioplasty is more challenging as compared to the native coronary artery angioplasty. Why? Because of 3 reasons. First of all, stent restenosis is a little higher in graft angioplasty. We are talking about saphenous vein graft. Secondly, there is a high chances of no reflow phenomena or slow flow phenomena after doing an angioplasty or putting the stent, because the material which is degenerative material, this embolizes into the distal circulation, and that hampers the result, and therefore you don't get result too good as compared to this. And third is of course the long term efficacy of patency of the graft, which I was covering, how to have a long term patency of saphenous vein graft medically. So coming to the first point, that is restenosis, which is higher. If we see the graft angioplasty restenosis versus native artery angioplasty restenosis is higher in graft angioplasty despite having a higher bore, and that is the data which has shown that is about 10 to 15 to 20% restenosis. So what to do about that? Of course, When it was initially planned, it was bare metal stent was being used, and now drug-eluting stent is the actually being used for so many purpose. So graft angioplasty always drug-eluting stent. GP2B3A receptor antagonist may not have good role because data have shown. Although I would be personally using GP2B3A receptor antagonist in all the patients with saphenous vein graft. Coming on to the main important problem, which is a no reflow or slow flow phenomena. So we have a distal protection. There are protection devices that will protect the embolic material or degenerative material to distally embolize, and that can be two types. One is distal protection, that means you put a protection device distal to the lesion. Another is proximal protection, we put a device inside the graft before the procedure in the proximal to the blockage. So distal protection devices are two types. One is filter wire, another is balloon occlusion. Balloon occlusion is more cumbersome, but it is easier to do it because you have to, at the time, during time procedure, you cannot see what is going on, where you put it. You have to do a manipulation, and then of course if you are good interventional cardiologist, you can do it. Filter wire is more commonly used, where you put the filter wire beyond the lesion, but after crossing the balloon wire, the PTCA wire, and then you do balloon dilatation, and then you put a stent, and then whatever amount of embolization, you capture it out and you remove it, and that gives a very good result, and this is commonly used. And there have been so many randomized trial, protection versus no protection. It has shown that the protection is much easier and better to do it. Coming on to the Proxis device, which is a proximal occlusion, that is a very good thing because you put a device before putting a wire. So even the embolization will not happen while you are crossing the lesion with the wire, and that is most important thing to do, but it is little more learning curve. So many of the interventional cardiologists are not using proximal devices, they are using only filter wire devices, which is distal to the protection and gives a reasonably good result. The trial which has compared the proximal device and the distal device have shown a little more efficacy of proximal devices versus distal devices. Coming on to how to keep the graft patent long term. So there have been 2-3 trials which have shown that efficacy of statins. I would recommend all bypass surgeons, all physicians, all interventional cardiologists who are following up their patients post bypass, that statins should never be discontinued despite having a normal cholesterol levels. There was a trial which has shown that 40 milligram of simvastatin, when simvastatin came, now we have atorvastatin and rosuvastatin, that 40 milligram of simvastatin given for 3 years, follow up, the graft worked much better as compared to those patients who did not have statins. So statins have a very good role, it should always be used. Secondly, the role of antiplatelets. It has been seen that if we give clopidogrel along with aspirin, the results and patency of saphenous vein graft is more, and therefore it should be given unless there is a major contraindication for dual antiplatelet. If the patient is more elderly, about 80-year-old, but any patient who is beyond 55, 60, 75, without any major bleeding history, without any intracranial hemorrhage, without any cerebrovascular accident, without any bleeding ulcers in the gut, they should continue to have dual antiplatelet as we do in the angioplasty stenting. So this is a summary. Just to summarize again, saphenous vein graft is challenging. 3 important problems: restenosis, distal no reflow phenomena, and of course how to keep it patent. The protection devices have a major role. It should be used when there is a degeneration. Young graft just recently blocked, you may not still require a distal protection or an proximal protection devices, but when in large thrombus you can see a degenerative material, it's not thrombus, degenerative material plus thrombus, as a sluggish flow, you feel that this is going to embolize. It's better to use a protection device before doing angioplasty. I am Dr. Professor Vivek Gupta. I was talking about saphenous vein graft angioplasty or post bypass angioplasty. One more thing, very important, if you can see a native artery which is supplying an occluded saphenous vein graft, and if you can do angioplasty of the native artery, it is always preferable to do a native artery angioplasty with stenting rather than going for a saphenous vein graft angioplasty. Thank you very much.